Hello everybody, and welcome back. I have Gary Green here for our usual talk. Been doing this for a long time, but the topics seem to not have changed much. These infections seem to go on and on and on. So I have some new information today and some new workflows that are going to be very helpful,
right.
Particularly in the realm of the monkeypox. So let's go ahead and jump in and first look at our demographics around COVID. Certainly not something you're reading about on the front page of the paper anymore, and you can see that the testing and the cases slowly coming down, and in the top right corner you'll see that outpatient symptomatic still 16% positive on testing for outpatient symptomatic, still very high. No new variants on the horizon, right, Gary?
Right.
But when you look at the magnitude of where we're at, certainly we're coming down. We're still in the middle of a bit of a surge, still the BA5 surge, so you have to keep that in mind. Hopefully, though, clinically it's slowing down for you. Is there much going on in the hospital or kind of status
Yeah, we're
quo?
still seeing steady cases in the hospital, steady cases in the ER.
Yeah.
We're not seeing as many unvaccinated people hospitalized, which is great,
Okay.
but it's clearly now become such an endemic outpatient disease. It's kind of like the flu season. It feels like that in the way of URI symptoms.
Well, it's certainly persisting for a long time now. All right, let's move on to vaccines. Again,
So,
the need for vaccines.
Right, so there is, because we're still having the surge with BA5, we're expecting a couple new vaccines coming up very soon. So the FDA is going to vote on 2 bivalent mRNA vaccines, one from Pfizer and one from Moderna. The bivalent vaccines have 2 pieces in them, the ancestral piece, and then also an Omicron BA.4/5 strain, which is good. And the vaccine data looks really good. It's going to be before the FDA in September, and we expect them to be out early fall. So at the time we're going to be vaccinated for flu, we're also going to be vaccinating for bivalent COVID. What's new on the scene is that Novavax is also, which is a protein subunit vaccine, not an mRNA vaccine. They're presenting data to the FDA as well. Now Novavax has already approved their vaccine for dose 1 and 2, but this is their booster data. The data for Novavax looks really great. It looks good. So what's going to happen is that which vaccine are you going to get? Which booster are you going to get? And that's going to come out to the primary care docs. They're probably going to be equivalent, but if there is a little bit of a better one, I'll certainly let you know.
Hopefully we'll get some more data on that too. I read some articles last night in the New York Times that there's not a lot of data in humans on the new boosters, and so there's going to be a little bit of a push of people wanting that human data.
Right, and
time will tell.
Yeah, the nuance there with the boosters is that the UK already approved it, right? So now that the UK approved it, the rest of the world's like, what about us? And the other thing is that the boosters in the UK were really tested in a BA1 variant period. And so we're now in a BA5 variant period. So again, sometimes there's some nuances there, but the boosters look really good.
Good, that's the good news. All right, off to the new thing, relatively new, monkeypox.
Yeah, so we're going to present a lot of data today on monkeypox, and I thought this would be just more educational to kind of give everyone perspective about it, and then we're going to talk about a workflow. I want to shout out really quickly to Dan Early and to Sarah Prysock for their work on the workflow as well. So I put in here, this is a slide I showed before, but I updated it. So this just shows in the red box kind of where we stand right now, 44,500 cases worldwide outside of Africa. In the US, we have almost 16,000 cases. California has 2,600 cases. Sonoma County has 34 cases. In the US so far, there have been no deaths. About 3.6 patients are being hospitalized who test positive for monkeypox, and most of that is for pain control. So we haven't really seen rare, severe cases in the US so far, and certainly no deaths. A number of children have been infected in the US, and that's thought to be from household contacts of people who are positive. I also wanted to take a step back in an educational format and show this next slide. Now, what about the orthopox virus group in general? Variola was smallpox, and smallpox was only seen in humans. And when a virus or a pathogen is only in one host, one species, then there's an opportunity to eradicate it. Later on, we're going to talk about polio, which is the same thing. But remember that monkeypox, like vaccinia, like buffalo pox, like cowpox, are actually zoonotic diseases. They're also seen in animal populations, which makes it much more difficult to eradicate them. So there's always going to be an animal reservoir in Africa where this virus circulates. We're just the wrong host. But because it's a zoonotic disease, eradication is going to be somewhat difficult. I thought that was just kind of helpful to the docs in general from an educational standpoint. Now we're going to look at the monkeypox data. So this next slide shows you what's going on worldwide. And worldwide, the United States has the greatest number of cases, followed by Spain, Brazil, and the UK. But if you look at the cases per population, the US is not at the top there. Spain has the greatest number of cases per population, followed by the Netherlands, followed by Portugal, and then behind that is the UK, and then we fall in beneath the United Kingdom. So we do have the highest number of cases, but because we have such a large population, if you look at population dynamics, it spreads out a little bit different. In the next slide, I'll show you kind of what's going on in the US. Last time we talked about that New England Journal of Medicine article, and I kind of put that down here. That's when that article was published, and we've seen cases continue to rise. The top 5 states are New York leads it right now. New York and California go back and forth. California, 2,600 cases, Florida, Texas, Georgia, all above 1,000 cases. Currently, the CDC is stating that 35% of swabs are coming back positive. That's a lot.
That is a lot.
You know, more than a third of the swabs that are sent to labs and reported to the CDC are positive, which tells us that the prevalence and the infection rate of monkeypox is going up in the United States. The next slide is California data. California data looks like the US data, but I want to kind of highlight a few things. 2,600 cases in California. If you look to the top right, in the top right, I'll show you that Los Angeles County is leading California, followed by San Francisco. San Francisco has just been almost less than half of the cases of LA County. And then even Sacramento and Santa Clara make the top 10. Sonoma County sits at 34 cases. And then in the lower right-hand corner, I kind of broke it down by demographics. 1.4% of cases are women, so there have been some female cases, but male cases predominate in about 98%. Men who have sex with men, clearly the predominant. So this outbreak and this epidemic hasn't really changed. It's still in the MSM population because of high-risk sexual practices, mainly anonymous sex, multiple sex partners, but there are also some caveats of like chemsex, which is people who are having sex using enhancing poppers, nitrates, methamphetamine, ecstasy, ketamine. And there's also things like transactional sex, where people actually have sex in order to find housing, have sex in order to get drugs. And so there's some high-risk sexual practices that are happening, and that's really leading and driving this epidemic. There was a case presented recently of someone who was just at a concert. It was a gay man at a concert, did not have sexual activity, but just from dancing around in that arena, probably had close contact with someone. Again, it's intimate contact, not casual contact, and still protracted it. And that case was in the news from Stanford, and it's going to be published. So it's still intimate contact. Most of the cases, age 25 to 45.
And you know, that one case is a bit of an anomaly because it was non-sexual but intimate contact in a high prevalence group setting.
Right.
So it wasn't just a household.
Yeah, and the CDC they actually state that even close contact venues, you know, like a concert, is going to be a chance of intimate contact, which then will support monkeypox transmission. We haven't seen this spill over yet. We're kind of waiting and watching for that. Will it spill over more into the heterosexual population? We don't know. Will we see this on college campuses? We don't know, and some colleges are getting ready for that. Will they see this in some contact sports like wrestling, you know, or rugby? We haven't seen that yet, and that's yet to be determined if this will spill over into other populations. So far, it's not predominantly in gay men, and men who have sex with men, and hopefully, as more vaccine comes out, and hopefully as public health messaging speaks to that community, we'll see less and less transmission.
So let's talk about vaccines. So all of our vaccine is going to come from Sonoma County Public Health. We know it's limited. You have 20 vials now, which is going to be approximately 100 doses.
Right.
We hope more will come as we use that, but we're about to start delivering vaccines to our patients.
Right. So the big picture is that this vaccine is in the national stockpile. So this vaccine has already been is already in location by the federal government, and because it's in the national stockpile, it has to go out through public health measures. So the public health department is determining where vaccine goes.
Yeah.
And like you said, we at Sutter have 20 doses right now.
Yeah.
Because it's in the national stockpile, we can't buy it.
Right.
And now we're kind of limited in where it gets to. And so we're earmarking that. Currently the guidelines are, and they haven't changed from last week, only people who've been exposed to a confirmed or suspected monkeypox case or are in high-risk situations where they've been at a venue where there's been monkeypox spread, and that's called post-exposure prophylaxis. That's the only time we're going to be vaccinating because of vaccine inavailability. In the future, when we get more vaccine, we'll go to pre-exposure prophylaxis. People who may be in a setting of close contact with someone, and that'll be what's called PrEP, and we're not there yet.
Okay.
Many patients are going to be asking for that.
Okay. So with that in mind, let's go to the next slide. Let's look at the workflow that Gary and Sarah and his team have created. And this is a high-level workflow, but I want to point out right away that the intent, and I want to thank Gary and his infectious disease team, the intent here is to keep the vaccine eligibility and criteria and ordering of vaccine off the plate of the clinicians.
Right.
And your team is really going to take on that responsibility. So let's just walk through this workflow that here. So starts at the top with a message or a telephone call, contact with the patient coming into the office. And when we get into our fully trained format, it will be the MAs who will receive that first, and will have the ability to do the screening at that level prior to it getting to a clinician. And we'll open up this smart phrase in a moment to tell you what's in there. So the MAs would do this screening, and based on whether or not a patient is qualified, if they are qualified, then they will be sending that on to the ID monkeypox team. And it's that team that they will then confirm their eligibility. The vaccine will be pended for Dr. Green to sign. So none of our clinicians will be able to directly order vaccine. It's all going to go through this team. It's all going to be signed off by Gary. He's going to have a sore hand from signing these off. So that's important for us to know. Two things I point out is that we're really trying to keep it off the plate of the clinicians, and two, access to the vaccine, since it is limited, is all going to go through Gary and his team. So Gary, do you want to walk through the
Yeah, so
phrase?
on the next slide, the smart phrase, this is the screening smart phrase that's going to be, you can use it by a physician, you can use it by MA, and it's Smugger, MPX for monkeypox screen vaccine. If you just put in .smgr for Smugger, MPX, this will come up. And Sarah put it's really good, it's really a drop down that lets you know if someone is approved for vaccine. Now again, when vaccine criteria changed by the CDC, we're going to change this in real time. So this will be updated. You don't have to worry about updating this. We're going to update this. And then at the very bottom, I put there what you guys want to know. This is the pool. So the pool is PWFSO, infectious disease, MPX VAX. So MPX VAC. And that's how you route the messages to the pool. If you have specific messages, you can certainly send me a staff message if you're kind of wondering about certain things, if the criteria changes. But I'll be sending, when the criteria does change, I'll be sending out an email to the providers, and we'll probably put it on this video as this changes. And it's a fluid thing based on vaccine availability.
Right.
So it will change in the future when we have more vaccine, and our workflows may change a little bit. At some point, will we ever have vaccine in the clinic? I don't know, because of the cold chain requirements from CDPH about how vaccine gets to one place and another. You can only move it once when it's frozen, and so it may have to live in a kind of a hub.
So similar to COVID.
Yeah, very similar to COVID.
Gary, I want to point out one thing in your smart phrase, MPX. So I think I heard that MPX is now the accepted name for this, or they still, I heard that FDA or somebody, CDC, is starting to use and encourage that instead of monkeypox.
Right, so MPX is the accepted nomenclature for monkeypox. And now we're not talking about the Congo clade or the Central Africa clade or the West Africa clade. The WHO is trying to call that clade 1 and clade 2.
Okay.
So clade 2 is what's circulating now. Will we get away from calling it monkeypox? Because it is a bit of a misnomer.
Yeah.
It's not endemic to monkeys. It's
Right.
endemic to
Right.
some kind of a rodent or a small mammal that we don't know about in Africa. So MPX is the nomenclature for
Okay,
monkeypox.
so you'll be seeing that more.
Yeah.
Okay. You want to talk about polio?
So we've had
Good topic.
we've had a couple of messages from the docs, and certainly it's in the news. My wife's asked me about this as well from patients. There's some polio in the news based in New York City, and based on that, what should we do regionally? The immediate answer is nothing. You're fine. But I want to just give you the data so you can talk to your patients. There was a single adult patient in New York City who had polio, and it wasn't wild type polio, that's important. It was vaccine-derived polio, so attenuated polio. So a 20-year-old male was traveling in Europe, probably had contact with someone who recently got oral attenuated polio virus.
Yeah.
And we don't use that anymore in the United States, but they use it in parts of Europe. That person got infected with this vaccine-derived attenuated virus and actually got admitted to a hospital in New York when he came back from travel with fevers, chills, and later on leg paralysis. And it's not very common that vaccine-derived polio gives you an illness, but this was an unvaccinated person, so they were more not immune to it. So there's been no other cases in New York. This happened a while ago. This is in July 21st. We haven't seen any other cases, but the UK also had a case of vaccine-derived polio, and they started looking at their sewage water. So New York started looking at their sewage water for virus. There was none in New York City, but a couple of the northern counties showed some attenuated virus of polio in their sewage water. New York was concerned about this because they have some populations where only maybe 50, 70% of patients are vaccinated. So there are some pockets of unvaccinated communities there, and they were worried about this getting out even in an attenuated fashion. But there haven't been any more cases. So what to do about us? Nothing. So I'll go on to the next slide. So polio, there are no cases in California and no cases in any other state except New York, and New York only has this single attenuated case. It's not wild type polio. So of course, if you have someone who's unvaccinated, you want to vaccinate them. My wife asked me, I have a 97-year-old patient who never received polio vaccine. And there's some options there, and I just said, give them the primary vaccine for IPV, inactivated polio virus. But certainly there's no indication for boosters, and there's no indication for serology. So I would say from a California perspective, it's much to do about nothing. And to give you a little clinical vignette on polio, it is endemic, wild type polio is endemic in Pakistan and in Afghanistan. So the World Health Organization is trying to lock that down. There have been a couple cases that have traveled from those countries, and there's been two cases of wild type polio in different countries of Africa, and they don't want that to spread if they're unvaccinated. But vaccine-derived polio is not very common, and that's why we're not using oral polio vaccine in the United States. It's not really going to be an issue for us. But just in case your patients are asking, I thought it'd be good for you to kind of have a little bit of information about that.
Yeah, interesting. So it's really not news. This possibility has always existed.
Yeah,
it popped up now.
It isn't news, but you know, the press are interesting because they're kind of making this a big deal. I mean, and we're so kind of exhausted with COVID pandemic, and now we've got this monkeypox thing that we have to pay attention to. You don't need to pay attention to the polio thing. So I think the press is making a bigger deal of it than it really is outside of New York. If I was in New York Department of Health, I'd be concerned, I'd be watching it, but I don't think we need to watch it here.
Great, thank you. Well, I'm just going to finish up with some more upbeat things. First one is just a reminder, just a couple days ago on Monday, you received this slide that says you are invited to our fall picnic. So October 1st. So now is the time to send in your RSVP. We've been saying to you, save the date, but now we need to count how many salmon to catch and how many brisket to slay because we need heads. So please, this is for the whole family. Monday you got the first invite. We'll continue to do that, but we do need RSVP in advance. We're planning for 100, 150 people. So it's going to be important, and it should be a very, very fun event. And then my last slide is the last thing, which is very timely and coming up this weekend, is our quarterly opportunity to volunteer at the Empire Food Bank over here in the airport complex. So we'll be there from 9 to 12 on Saturday. So you can go to their website, sign up easily, or if that's too cumbersome, show up. Show up, a few minutes before 9 o'clock so they can register you and we can all come in. They have been sending out a lot of advertisements how the need for food from the food bank has really skyrocketed, and along with that, the need for volunteers. So we're hoping to help in that. So that's all we have today. Hope you enjoy your day. As always, please send us questions if they come up. Thanks.